Hello, I'm Oscar Benavides, a pediatric cardiologist at the Massachusetts General Hospital for Children. I'll be talking about recognition of cardiovascular disorders in children. In this presentation, we'll provide instruction in recognizing cardiovascular disease in children, particularly children who present with murmurs, chest pain, the evaluation of critical congenital heart disease in the neonate and the recent guidelines, cyanotic heart disease, palpitations, heart failure, and syncope. Heart murmurs are a very common presentation for pediatric patients. As you know, there are two primary heart sounds, the S1 and the S2. Heart sounds that occur between the S1 and the S2 occur during systole and are therefore referred to as systolic murmurs. Murmurs after the second heart sound, or S2, up until the first heart sound, are referred to as diastolic murmurs. Murmurs that include both systole and diastole are known as continuous murmurs. In general, there are two types of heart murmurs that are found in children. One are murmurs that are not caused by a structural abnormality, and these go by various names, including the Stills murmur, functional murmur, innocent murmur, and benign murmur. Essentially, all suggest that the underlying cardiac anatomy is normal. However, you could appreciate the heart sounds. The second type of murmur is a murmur that is from a cardiac structural or functional defect. This includes septal defects, valve abnormalities, blood vessel narrowing or obstruction, the presence of abnormal blood vessels, and increased flow across a vascular structure or valve. We sometimes refer to these as pathologic heart murmurs. Murmurs and auscultation. To best define cardiac murmurs, it is important to evaluate the heart systematically. This diagram depicts four common locations of places for auscultation, including the aortic area, pulmonic area, the left third intercostal space, the mitral area, and also the tricuspid area. Other areas that should also be evaluated are, however, are infrequently discussed are the infraclavicular areas, mid-axillary areas, and also the interscapular area in the back of the patient. These different areas give you a different acoustic vantage point to the heart to approach diagnosis of a heart murmur. Murmurs appearing in the aortic area are frequently associated with aortic pathology, and similarly, murmurs over the pulmonic area are associated with pulmonic pathology. However, it could also be the location where a patent ductus arteriosus murmur is also appreciated. Right ventricular outflow tract obstruction lesions can also be appreciated in the third left intercostal space. Tricuspid valve abnormalities could also be appreciated anteriorly over the tricuspid area. Over the mitral area, mitral valve pathology, including left ventricular outflow tract lesions, can also be appreciated here at the apex. Peripheral pulmonary stenosis can be appreciated over the mid-axillary regions. Other murmurs, such as a venous hum, can be appreciated in the infraclavicular area. And other pathologies, such as coarctation of the aorta, can be appreciated in the interscapular area. This diagram depicts the position in the cardiac cycle when a murmur can be appreciated and what its corresponding pathology is. In the left-sided pane, we have systole, and the right-sided pane is diastole. S1 indicates the first heart sound. P2 and A2 together represent the second heart sound, P2 representing the pulmonic component, A2 representing the aortic component. A murmur of aortic stenosis is appreciated during systole, it being a crescendo-decrescendo murmur over the aortic position, whereas a murmur of aortic insufficiency is a complete decrescendo murmur occurring over diastole. This can also be appreciated both over the aortic area and over the apex of the heart or near the mitral area. Similar to the aortic stenosis murmur, the pulmonary stenosis murmur is appreciated during systole, and again is also a crescendo-decrescendo murmur. However, it is best appreciated over the pulmonic area. And pulmonic insufficiency, also best appreciated over the pulmonic area, is heard as a decrescendo murmur over the pulmonic area. A murmur of mitral stenosis is appreciated a short period after the onset of a diastole and heard through most of the diastolic period with no presence during systole. Again, this would be appreciated over the mitral area. Mitral insufficiency or mitral regurgitation is a systolic murmur and is heard continuously across the systolic frame and typically described as blowing. This is also true of the tricuspid insufficiency or tricuspid valve regurgitation murmur. The murmur of an atrial septal defect is also heard during systole over the pulmonic region. Interestingly, the contour and the quality of a murmur caused by an atrial septal defect is similar to that of a murmur from pulmonary stenosis. The murmur from an atrial septal defect is not from the blood flow crossing the septal defect, but actually from the increased blood flow coursing over the pulmonary valve. Ventricular septal defect murmurs are classically also described as blowing murmurs heard throughout systole of approximately the same intensity. Murmurs of patent ductus arteriosus are the first continuous pathologic murmur that we are discussing here today, and again is heard both during systole and diastole, classically over the pulmonic region, the left mid-axillary line, and posteriorly in the interscapular region. Other pathologic heart sounds include the S3, which typically represents blood sloshing into a relatively dilated ventricle, however, can be normal in highly trained athletes, and follows the A2 and P2 component of the second heart sound. And S4, however, occurs very late in the diastolic frame, preceding the first heart sound, and it typically reflects atrial contraction against the stiff ventricle. So the take-home message when to refer a heart murmur for cardiology evaluation are the following: pansystolic murmurs, as they may represent regurgitation or ventricular septal defects, any murmur that would be considered large or harsh, which may represent aortic stenosis or pulmonary stenosis murmurs. Murmurs located at the upper sternal borders should also be referred, as they may represent aortic stenosis or pulmonary stenosis. Systolic clicks, they may represent valve abnormalities. An abnormal second heart sound, which may represent pulmonary hypertension. Any diastolic murmur should be considered pathologic, as it may represent aortic regurgitation and mitral stenosis. And a continuous murmur, which may represent a patent ductus arteriosus or coronary artery fistula. Now moving over to pediatric chest pain. This is a very common symptom in both children and adolescents, and because the frequency of cardiac-based chest pain in adults is so common, presence of chest pain in pediatrics contributes significantly to both parental and patient anxiety and may actually result in multiple school absences or restriction from sports. Pediatric chest pain is responsible for almost 20% of all new pediatric emergency department visits and up to 5% of inpatient pediatric cardiology consultation. The interesting fact is that pediatric chest pain is typically not associated with cardiac pathology. This is in contrast to what families or the lay person's estimate of the prevalence of cardiac disease in patients with chest pain. As this slide depicts, although a family's perception of cardiac chest pain or a cardiac etiology of their child's chest pain may be upwards of 50 to 56%, the actual medical diagnosis of there being a cardiac etiology associated with chest pain is only 1 to 4%. More common etiologies of pediatric chest pain when identified are musculoskeletal, respiratory tract infection, psychiatric. The vast majority of these cases, however, we're unsure or the cause of pediatric chest pain is idiopathic. To underscore this point, there's a study that was performed in a high-volume outpatient pediatric cardiac center evaluating patients with chest pain. That is, these are patients referred to a pediatric cardiologist. Over the duration of the study, 406 patients were evaluated. And among those 406 patients that were evaluated, only 5 of the patients had a cardiac condition diagnosed, representing only 1.2% of this population. Pericarditis represented 2%, or 2 out of the 406 patients seen, and arrhythmia represented 3. Even among patients that do have an underlying congenital cardiac diagnosis, chest pain is not always associated with them, including the diagnoses that we would typically associate with chest pain. For example, aortic dissection in this study of patients from age 7 to 21 years over a 10-year period that did not present with chest pain. Coronary anomalies, which is usually feared in patients with pediatric chest pain, only presented in 1/4 of the cases. Cases that did have an underlying cardiac disorder that were associated with chest pain were more frequently pericarditis. 95 of that patient population presented with chest pain, myocarditis, and pulmonary embolus. Overall, among all the lesions associated with chest pain, only 35% of them actually presented with chest pain as their presenting symptom. This work has led to different strategies to improve the quality of chest pain evaluation in pediatrics. Multiple studies have suggested that chest pain assessment can be performed very well with history of the present illness, a patient's medical history, knowledge of medications, family history, social history, physical examination, the electrocardiogram, and the chest X-ray. Now, the patient illness history, there are parameters that are concerning for cardiac etiology. And those are anginal quality of chest pain, that is chest pain which is with exertion. Chest pain that radiates classically as anginal chest pain to the jaw, throat, left shoulder, and down the left arm, or to the back. If chest pain is associated with both syncope with exercise, is a red flag. Chest pain that increases when a patient is supine is also concerning for a cardiac diagnosis, such as pericarditis. Also, chest pain associated with fever and or rash could be concerning for conditions such as myocarditis or pericarditis. Patient's past medical history is also very important. There are certain parameters that are concerning for cardiac etiology chest pain, including if a patient has a known hypercoagulable state, that is having a known clotting disorder or being postpartum within 6 weeks of presentation. If a patient has a history of connective tissue disorder that may predispose them for vascular event, such as patients with Loeys-Dietz or Marfan's. Patients with a history of vasculitis, such as Kawasaki's disease, as these patients may occasionally develop coronary artery thrombosis. Also, patients with a history of autoimmune disease, such as lupus, which may also present with a pericarditis and very large pericardial effusions. Family and social histories are also very important in assessing potential of a cardiac etiology for chest pain. Family history of sudden cardiac death is an important factor. Family history of connective tissue disorder, or family history of an unexplained death, such as an odd car accident, may also be concerning for underlying cardiac pathology. Social history, such as illicit drug use, such as stimulants, may cause coronary artery vasospasm and even myocardial infarction in the pediatric population, and is an important part of the history. On physical examination, other parameters that are concerning for cardiac etiology involve relative ill appearance. If a patient on vital signs has increased respiratory rate, fever, tachycardia. If there's an abnormal cardiac examination, if there's a pathologic murmur present, heart sounds are distant, or if there's a friction rub, or if the patient may appear syndromic, Marfan's, Williams, or Turner's syndromes. There's some preliminary tests that could point to cardiac etiology, one being chest x-ray, finding cardiomegaly, may again indicate there may be myopericarditis, or ventricular dysfunction, or even pulmonary edema. Electrocardiogram, such as in this electrocardiogram in a patient with pericarditis, shows hallmarks of such a condition, including PR depression, nonspecific T wave elevation. Both of these features can be seen with pericarditis or a pericardial effusion. We'll review a case of a patient with chest pain. This is a patient who is 9-year-old female presented with chest pain. Her history of present illness is that she presented with cough, myalgia 7 days ago. Fevers past 3 days. There had been no history of syncope or rashes. There had been some emesis with epigastric and chest pain. There was some shortness of breath. No symptoms prior. She's previously healthy. Past medical history, she was born full term, had tympanostomy tubes in the past. Medications were none. Family history was negative. She was a hockey player. On physical examination, she was noted to be febrile to 39.1, tachycardic, somewhat tachypnic with a respiratory rate in the 30s, normotensive, oxygen saturations normal on room air. She appeared tired, had jugular venous distension. Her lungs were clear, had good aeration. Her heart sounds were distant. She had a normal S1 and S2. There's a questionable of S3 on auscultation. Chest pain was worse when she was supine, and there's a friction rod present. Her liver was non-palpable, and her pulse varied with respiration. This was her electrocardiogram, which showed diffusely mild tachycardia and low voltages throughout, including nonspecific T-wave abnormalities. With the details so far, does this appear to be a cardiac diagnosis or non-cardiac diagnosis? And if a cardiac diagnosis, what could be the potential? And looking at the electrocardiogram, again, we appreciate that the voltages are fairly low in this patient. She has a friction rub, fever, chest pain that's worse while being supine, and a viral type presentation. Potential diagnoses of this include a cardiomyopathy, pericardial effusion, and subsequent secondary to pericarditis, including myocarditis. This patient was referred to pediatric cardiology in the emergency department. A chest X-ray was obtained, which showed striking cardiomegaly. To evaluate the potential of myocarditis or myocardial injury, secondary to a viral infection of the heart, troponins were sent and they were normal, as was the creatinine kinase with MB fraction was also normal. In the still frame of the echocardiogram, it shows a very large pericardial effusion around this heart, causing significant compression. Her diagnosis was pericarditis, the cardiac etiology of her chest pain. This fluid was subsequently drained, and the patient recovered as her viral syndrome presented and improved. The take-home message for chest pain is usually with a careful history and physical examination, a cardiac cause of chest pain can be ruled out without the need of multiple diagnostic tests. And in the absence of fever, positive findings on cardiac or pulmonary examination, or symptoms during exertion, a cardiac basis for chest discomfort is unlikely. We'll now discuss critical congenital heart disease. Congenital heart disease still represents a leading cause of infant death from a congenital malformation. It's present in 9 in 1,000 live births. Approximately 17 to 31% of these births involve critical congenital heart disease. The definition of critical may vary from textbook to textbook, but in general signifies that there will be severe morbidity or mortality if the condition is left untreated for the first days or weeks of life. Critical congenital heart disease is present in approximately 4,800 births per year. Recently, there has been some discussion and implementation of pulse oximetry screening for congenital heart disease. Many children with critical congenital heart disease may not be hypoxemic, and clinical appearance of their cyanosis might not be apparent unless they're profoundly cyanotic, with saturations requiring to be as low as 80 occasionally for a clinician to appreciate it. The thought of using pulse oximetry in congenital heart disease screening was thought to be promising, given that it's relatively routine in many clinical areas. It's non-invasive and inexpensive and fairly straightforward. And presence of hypoxemia would provide further evidence that a patient may require ongoing evaluation for a congenital heart lesion. To discuss two large classes of critical congenital heart disease lesions are those that are ductal-dependent circulations. You have conditions such as hypoplastic left heart syndrome depicted on the right-hand side of the screen of a systemic dependent ductal circulation or a pulmonary ductal dependent circulation. Following birth, the patent ductus arteriosus closes. If you have a systemically dependent ductal circulation, such as in hypoplastic left heart syndrome, once the patent ductus arteriosus closes, there is insufficient volume of blood that could enter the small left ventricle, exit through the diminutive ascending aorta to supply both the brain, head, arms, and lower extremities. Once the ductus arteriosus closes, essentially the blood flow to the systemic circulation is shut off. This results in profound systemic hypoperfusion and shock. When there is a ductal-dependent pulmonary circulation, as the patent ductus arteriosus closes, there is loss of pulmonary perfusion. As a result, the heart and lungs can no longer deliver oxygen to the blood, nor remove carbon dioxide from the circulation. This may cause profound perfusion, cyanosis, and acidosis. As we discussed, most critical congenital heart lesions are ductal dependent, and their prenatal circulation is maintained by the presence of the patent ductus arteriosus. And it's not only until after this patent ductus arteriosus closes is there a collapse of the systemic or pulmonary blood flow. Unfortunately, this does not occur until after discharge from the newborn nursery in some of these children. And the early signs may not be apparent during the first few hours or a couple of days of life in the newborn nursery. Unfortunately, delayed diagnosis is associated with infant death. 25% of critical congenital heart disease is not diagnosed until after discharge. For example, 6% of infants with transposition of the great arteries die at home following discharge, which is unfortunate, as the outcomes of congenital heart surgery for this lesion approaches 0% mortality. Approximately 2% of infants with any congenital heart disease die before the identification of heart disease. This delayed diagnosis of critical congenital heart disease results in approximately 2 deaths per 10,000 live births. Given the mounting evidence, the American Academy of Pediatrics, with the Health and Human Services, published a policy statement endorsing pulse oximetry for screening of critical congenital heart disease. In this document, they specified and emphasized the importance of proper implementation screening protocol in this document. After 24 hours of age, or shortly before discharge, if the infant is less than 24 hours age, pulse oximetry should be performed in the right hand and the right foot. If at any time during the screening process the oxygen saturation is less than 90% in either the right hand or the foot, this results in a positive screen indicating identifying an infant in need of further evaluation for cyanosis. If the oxygen saturation is greater than 95% in the right hand or foot, and there is less than a 3% difference between the right hand and right foot, this is referred to as a negative screen, indicating there is no need for further evaluation of this infant, and usual care can continue. There's a middle area where if the infant tests between 90 and 95% of oxygen saturation in the right hand and foot, or if there's a greater than 3% difference between the right hand and right foot, a repeat screen is performed in 1 hour. At any time, the infant can either test positive for critical congenital heart disease or test negative for critical congenital heart disease. Should the second test be equivocal again, the study is then repeated in 1 hour. If the study again remains equivocal, this counts as a positive screen, and the child should be evaluated. For those patients with a positive screen, first require comprehensive evaluation for causes of hypoxemia. And in the absence of other findings to explain hypoxemia, critical congenital heart disease needs to be excluded on the basis of a diagnostic echocardiogram. This may be performed in a hospital birthing center, or the infant may need to be transported to another institution, or the use of telemedicine would suffice. And when feasible, consultation of pediatric cardiology prior to the echocardiogram performed is preferred. In conclusion, the critical congenital heart disease screening, that is a recent addition to the newborn screen, in addition to bilirubin screening and metabolic screening and hearing screening. And it prevents death and significant morbidity in newborns following discharge from the newborn nursery. Sometimes a clinician may be faced with an infant that is cyanotic. This either may be from the testing for the newborn screen or a presentation immediately following birth. Cyanotic lesions indicate saturations less than 95% on room air, or a PaO2 on arterial blood gas of less than 60. Again, they may have failed a hyperoxia test, which is a PaO2 of less than 100 to 150, with an inspired fractional oxygen of 100%. EKGs occasionally may be helpful in this situation, in that if it displays a superior axis, it may suggest a diagnosis of tricuspid atresia, a single ventricle type of heart disease. Chest x-rays may also be helpful in that they may display oligemic lungs, such as in this patient with a ductal-dependent pulmonary circulation, who lost pulmonary perfusion, and as a result, there's very little vascularity to the lungs. You may see congested lung fields or cardiomegaly. There are cyanotic lesions that are ductal dependent, such as tetralogy flow with severe or pulmonary stenosis. Any lesion with pulmonary atresia, transposition of the great arteries, and severe neonatal Epstein's are all examples of ductal-dependent pulmonary circulations. Non-ductal dependent cyanotic lesions include truncus arteriosus, tricuspid atresia, totally anomalous pulmonary venous connection, severe neonatal Epstein's, left ventricle mixing lesions without pulmonary obstruction, and tetralogy flow with pulmonary stenosis. The list of these diagnoses require input of a pediatric cardiologist and typically echocardiography to firmly establish these diagnoses. However, recognition of cyanosis is an important first step in this diagnostic pathway. Stenotic lesions must be considered in infants with low saturations. After this is recognized, cardiology should be contacted for further examination and echocardiography to establish a diagnosis. As mentioned, recognition is important to establish an accurate diagnosis and timely diagnosis. These infants may require the use of prostaglandins to maintain adequate pulmonary blood flow. Respiratory support, as prostaglandins occasionally can cause apnea in this patient population. And in addition, hemodynamic support to maintain blood pressure. Planning for interventional surgical procedures is fairly common in these infants. We'll now transition to palpitations. Palpitations is a sense of a rapid or pounding or fluttering of the heart. This can occur both with or without activity. And although typically benign, palpitations may be a symptom of arrhythmia. And it's important to understand the arrhythmia to be able to recognize heart conditions. It's very important to understand the context. What is the frequency of the palpitations? This is something that occur daily, or is this something monthly? Does it have an onset or offset? What is the nature of that? Is the onset of the rapid heart beating or palpitations gradual, or is it abrupt? Abrupt onset and offset may indicate a arrhythmia. How long do the palpitations last? They may last for seconds, minutes, or hours. Occasionally, they may even be fleeting. This may help with respect to diagnosing or planning for a diagnostic strategy for these. Are there any important associated symptoms? Presence of palpitations with either syncope, shortness of breath, or chest pain is a red flag. Are there any other associated activities with the palpitations? Are the palpitations at a proportion to the degree of exercise? Are they associated with diet or particular habits, whether these be illicit habits or less illicit, such as use of caffeinated beverages? There are many tools for the analysis of palpitations. They all have various strengths and detractions. The 12-lead electrocardiogram is an excellent and may point to structural abnormalities or presence of accessory pathways, such as in both Parkinson White. The electrocardiogram, however, is only a very brief snapshot in time and does not capture an arrhythmia unless the patient is actively having an arrhythmia at the time of the EKG. Inpatient telemetry can provide 24 hours of coverage, however, require inpatient presence. These units, however, do not typically quantify the degree or quantity of arrhythmia. Holter monitors are excellent for outpatient monitoring and may be used for 24 to 48 hours. They quantify the degree of arrhythmia, average heart rates, minimum, maximum heart rate, and can be correlated with the diary. These, however, may be less useful for arrhythmias that occur once a week, however. Event monitors are very useful devices and can be used for up to 30 days. They come in various varieties, including monitors that have a 1-minute memory into the past, in which case if the patient feels the palpitations, we're able to capture both the onset and offset of the palpitations. For less common events, there now exist implantable loop recorders, which are devices that are implanted underneath the skin and can be interrogated wirelessly to determine if there's an arrhythmia present. We'll now discuss arrhythmias specifically. There may be tachyarrhythmias or fast heartbeats, which are both can be narrow complex or wide complex, and bradyarrhythmias, which may be secondary to a sinus bradycardia or varying degrees of heart block. Sinus tachycardia is a normal heart rhythm. Its characteristics are that it's greater than 100 beats per minute. The axis of the QRS complex and T wave are normal. And the variability between the RR complexes is also variable and shows gradual increase and decrease with physical activity. Sinus tachycardia is not pathologic under the appropriate conditions. Supraventricular tachycardia, however, is pathologic and typically indicates the presence of an accessory pathway. Occasionally, that accessory pathway is within the atrioventricular node. The characteristics are that typically the heart rate is over 200 beats per minute. However, it can be as low as 180 beats per minute in older patients. It has both an abrupt onset and termination, and the RR interval is fixed. That is, measuring the distance between this QRS complex and this QRS complex will be essentially identical to one later in this cycle. This is an excellent example obtained from telemetry showing the abrupt onset and offset nature of supraventricular tachycardia. At the beginning of the tracing, we see a sinus rhythm with a P wave followed by QRS and a T wave. This pattern repeats itself until there's an extra beat that initiates here, followed by a P wave, and then the rapid onset of supraventricular tachycardia. You appreciate the heart rate is faster given how close the QRS complexes are spaced to each other as opposed to one in sinus. Also note the loss of the P wave in its normal position. This rhythm continues, again, with a relatively monotonous fixed heart rate until it stops abruptly and returns to sinus rhythm. This correlates with patients' report of rapid onset and offset of tachycardia, and the presence of these symptoms during a history and physical examination should point to the likelihood of there being a pathologic arrhythmia. Atrial flutter is caused by a reentrant circuit located within the atria itself. Its heart rate is regular, like supraventricular tachycardia. However, its ventricular rate is relatively slower, usually approximately 150 beats per minute. The QRS duration is normal, that is narrow complex, and the P wave is replaced by the sawtooth type flutter waves. The flutter waves typically beat at a rate of close to 300 beats per minute. Sinus bradycardia is a slow heart rhythm. Typically, sinus bradycardia does not cause specific symptoms. It typically has a relatively regular rhythm. Its rate is less than 60 beats per minute. It has a normal QRS duration and a normal presence of P waves. This can be seen in patients on a beta blocker. Also can be seen in patients with anorexia nervosa. Complete heart block is a pathologic rhythm when there is no electrical communication any longer between the atria or the ventricles. In this rhythm, we see a P wave essentially marches through the QRS complex at a rate nearly double that of the QRS complex or the ventricular rate. This can be seen in patients following congenital heart surgery and also with Lyme disease. Ventricular tachycardia is a wide complex tachycardia with rates typically greater than 120 beats per minute. Can be monomorphic, that is, have the same QRS morphology, and typically has a T wave axis, which is opposite the QRS axis. And there may also be presence of AV dissociation in patients with ventricular tachycardia. This can be a life-threatening emergency. Can also be seen in patients with myocarditis or various toxidromes. Polymorphic ventricular tachycardia, or Torsade point, is different than ventricular tachycardia in its morphology of the QRS complex. given the appearance of a wire spinning around itself. The rate can vary between 150 and 250 beats per minute. Unlike regular ventricular tachycardia, Torsade de points is a polymorphic ventricular tachycardia where the appearance of the QRS complex and T waves varies. These patients may also have AV dissociations, can also be in toxidromes and in heritable arrhythmic disorders such as long QT. The conclusion of palpitations, arrhythmia, it's very important to consider the history to understand the association with symptoms, the palpitations with physical activity, and also the associations with diet and habits. And there are many available tools for assessment and definitive diagnosis in patients with arrhythmia and palpitations. Congestive heart failure. Congestive heart failure is really the inability of the heart to maintain the adequate cardiac output for metabolic needs. This can be the result of myocardial dysfunction, as in myocarditis or cardiomyopathy, from obstructive lesions, that is, lesions that do not allow the heart to deliver the blood where it needs to go, such as coarctation of the aorta or mitral stenosis, the presence of runoff or regurgitant lesions, such as aortic regurgitation or patent ductus arteriosus, or if the heart is unable to accommodate the blood volume or load to it, such as in ventricular septal defects or in other shunting lesions. The clinical signs of heart failure vary on patient age. And infants can represent and be seen with respect to a child having poor feeding or poor weight gain, tachypnea with feeding or tachypnea at rest. Older children could be dyspnea on exertion, tachycardia, presence of a gallop or a murmur, presence of wheezing or quote-unquote asthma. On physical examination, poor perfusion or hepatomegaly can be appreciated. The causes of heart failure can be congenital heart disease, as mentioned, obstructive lesions, regurgitant lesions, or shunting lesions, myocardial disorders, such as in myocarditis and cardiomyopathy, and also arrhythmias can cause heart failure. Some persistent tachycardic rhythms can weaken the heart muscle over time, contributing to heart failure. The etiology of heart failure can depend on the time of presentation. Typically, when an infant presents with heart failure, it's secondary to left-sided obstructive lesion, such as hypoplastic left heart, coarctation of the aorta, or critical aortic stenosis. Less commonly, pulmonary stenosis, totally anomalous pulmonary venous return can present with heart failure, and metabolic hypertrophic cardiomyopathy, as seen in infants of a diabetic mother. Infants from 1 week to 1 month can also still present with left-sided obstructive lesions, such as coarctation, but also presence of large left to right shunts, such as those with a large ventricular septal defects or a complete common atrioventricular canal. Those between 6 weeks and 6 months are also those infants and children who have large left to right shunts. Anomalous coronary artery origins can typically present during this time, however, are much less common. Also, metabolic cardiomyopathies may also present in this time as well. So the summary for heart failure is that the timing of presentation is important in considering the etiology, that there may be congenital lesions causing this, infectious or rheumatic problems such as myocarditis. There can also be myopathic, such as cardiomyopathy or metabolic diseases that can trigger myopathic changes or cardiomyopathies in these patients. We'll now discuss syncope. Syncope is a rapid and transient loss of consciousness associated with loss of postural tone or falling. There's also pre-syncope, which is a lightheadedness without actual loss of consciousness. Now, cardiac etiology of syncope is not terribly common, but is very potentially life-threatening. Syncope associated with palpitations, shortness of breath, chest pain, or physical activity, or even a family history of sudden death must be evaluated by a cardiologist promptly. In discussing of the cardiac etiology of syncope, we put them in three large categories, including arrhythmia as a cause of syncope, heart failure as the cause of syncope, and obstructive lesions. With respect to arrhythmias, prearrhythmias such as sinus bradycardia caused by a beta blocker could be an etiology of syncope in patients. This could be diagnosed by an electrocardiogram. Bradycardia caused by complete heart block can be seen in patients with a clinical history of Lyme disease. Also among patients who have undergone congenital heart surgery repair, such as ventricular septal defect repair or resection of the subaortic stenosis. These patients will present with bradycardia, syncope, and an abnormal EKG showing complete heart block. Congenitally corrected transposition of the great arteries is also associated with spontaneous development of complete heart block. There may be tachyarrhythmias or malignant arrhythmias associated with syncope and as the causes of them. Ventricular tachycardia with ventricular dysfunction can result in syncope. Supraventricular tachycardia in general is more associated with palpitations and occasional shortness of breath, can on occasion be associated with syncope. This could be diagnosed with an electrocardiogram demonstrated pre-excitation on the baseline EKG. There can also be malignant arrhythmias caused by long QT or Brugada syndrome. These malignant arrhythmias may be torsade or ventricular fibrillation, which can be seen in toxic ingestions and severe metabolic derangements. Obstructive lesions can also be an etiology. Obstructive lesions such as aortic stenosis are typically fairly obvious during a physical examination as they are associated with a very large heart murmur, and typically these patients have a long history of aortic stenosis. Patients with hypertrophic cardiomyopathy may also present with syncope. It may be that these patients may not have a significant murmur at rest, however, may demonstrate significant left ventricular hypertrophy on the electrocardiogram, as we see here on this electrocardiogram in the bottom right panel. Pulmonary hypertension can also present with syncope. In this situation, the pulmonary vasculature acts as the bottleneck in the circulation and does not allow adequate forward blood flow through the lungs to the left side of the heart and out to the body. This is an electrocardiogram of an unfortunate 7-year-old who presented with syncope and had an abnormal electrocardiogram indicating significant right ventricular hypertrophy by the RS finding in the right precordial leads. An echocardiogram demonstrated that she had systemic right ventricular pressure. Heart failure may also cause syncope. There are patients who present with viral symptoms, fever, malaise, chest pain, tachycardia, and an abnormal EKG who develop significant myocardial dysfunction. The significant myocardial dysfunction makes it that the heart is unable to pump adequately out to the body to maintain cardiac output, causing syncope when the patient is attempting to be upright. This is typically a late finding in patients with myocarditis and an ominous sign. Patients with a dilated or other forms of cardiomyopathy may have worsening heart function and can present with syncope. These patients, however, are also more likely to present with arrhythmia, as we discussed, could also be a etiology of syncope. Syncope summary. So cardiac etiologies of syncope are typically life-threatening and need to be addressed quickly. Please refer to a pediatric cardiologist if the syncope is associated with physical activity, any cardiopulmonary symptom or family history of sudden cardiac death. During this presentation, we discussed the following conditions: murmurs, chest pain. We discussed the topic of screening for congenital heart disease in the neonate, the presentation of cyanotic heart disease, palpitations, heart failure,